Hi everybody, and welcome to our module on protein synthesis inhibitors. There are a large number of antibiotics that function by inhibiting protein synthesis in bacteria, and we're going to talk about all of these in this module today. And the drugs that inhibit protein synthesis include the aminoglycosides and macrolides, tetracyclines and chloramphenicol, also clindamycin and linezolid, and then finally the streptogrammins. Let's start by reviewing some basic principles. Bacteria have DNA present in their cytoplasm, and in order to make proteins, they have to convert that DNA into RNA, and this process is called transcription. And there is a bacterial enzyme that does this called RNA polymerase, and that is the target of a tuberculosis drug called rifampin. We're not going to discuss that today, but I want to point out to you that there are drugs that interfere with a bacteria's ability to convert DNA into RNA. Now, once the bacteria have made RNA, they convert it into a protein, and that process is called translation, and that's where all the antibiotics we're going to talk about in this module work. So let's talk in a little more detail about how bacteria synthesize proteins. The entire process begins with a piece of mRNA that the bacteria wants to use as a template to synthesize protein. To initiate the process, the bacterial ribosome has to bind the mRNA, and there are two subunits to the bacterial ribosome, a 50S subunit and a 30S subunit. Next, a piece of tRNA comes into the picture, and then the bacteria begins to synthesize the protein by reading the mRNA, adding peptides, and translocating down the piece of mRNA as it reads the template. So basically, you can break this process down into three steps. It needs to be initiated, the tRNA has to be added, and then you have to add peptides and translocate. And the different protein synthesis inhibitor antibiotics are going to work on one of these three steps. The antibiotics that work on the initiation process are the aminoglycosides and linezolid. They block that process. Tetracyclines block the addition of tRNA. And then finally, there are three types of drugs that block the addition of peptides and translocation. That's chloramphenicol, the macrolides, and clindamycin. Now let's talk about the different antibiotics one at a time. The first group are the aminoglycosides, and this includes medications like gentamicin, neomycin, amikacin, tobramycin, and streptomycin. All of these drugs work by blocking the initiation of protein synthesis, and they do this primarily by binding the 30S subunit of the bacterial ribosome. This causes misreading of the genetic code, so the bacteria cannot divide and they can't produce cellular proteins. Now, some of the misread proteins will go to the cell surface and cause the bacteria to become more permeable to solutes in water. This will lead to bacterial cell death. And aminoglycosides are unique among the protein synthesis inhibitors in that they are bactericidal. Most protein synthesis inhibitors are bacteriostatic, meaning they stop bacteria from growing, but they don't kill them. Aminoglycosides are unique in that they kill bacteria. These drugs require oxygen for transport into the cells, so they're not effective against anaerobes. They also do not affect eukaryotic cells because eukaryotic cells have different ribosomes. In addition to the different ribosomes, these drugs are not transferred into eukaryotic cells. This means they're not going to be effective against intracellular organisms like Rickettsia and Chlamydia. These drugs can be used alone to treat serious gram-negative infections, although that's rare. Usually they're used in combination with other drugs. We'll talk about that in a minute. Streptomycin can be used to treat tuberculosis. It's an older agent. In fact, it was the first anti-tuberculosis drug ever developed. Nowadays, it's used in combination with other drugs for multi-drug therapy of tuberculosis. Neomycin is sometimes given prior to bowel surgery. It's poorly absorbed, so it stays in the gut. It's often given with a macrolide called erythromycin, and the two of these together decrease colonic bacteria so that patients are less likely to get an infection after their bowel operation. These drugs are often added to beta-lactam antibiotics because they have synergistic effects. This means that clinical studies have shown that the combination is more effective than either drug when it's used alone. Vancomycin and gentamicin are often given for endocarditis when you don't know which bacteria you're dealing with. Part of the reason is because this will cover Enterococcus, and Enterococcus is a rare cause of endocarditis, and it's difficult to treat, but this regimen works for it. Ampicillin and gentamicin are often given to newborn babies with meningitis because one of the potential agents for newborn meningitis is Listeria, and ampicillin covers that well, and this combination works well for many of the meningitis bacteria. Piperacillin and tazobactam is often given together with tobramycin for cystic fibrosis patients who have lung infections, and that's because those lung infections are often caused by Pseudomonas. The most common mechanism of resistance to these antibiotics is for bacteria to acquire aminoglycoside modifying enzymes. This means that the bacteria acquire an enzyme that modifies the drug structure, and once it's modified, it binds poorly to the ribosomes. There are two biochemical mechanisms by which these enzymes work. Some of them do phosphorylation. This is mediated by aminoglycoside kinase enzymes. And some of these enzymes do adenylation and acetylation, and this is mediated by bacterial enzymes called transferases. Let's talk about some of the toxicity of aminoglycosides. A very important toxicity is ototoxicity. These drugs are toxic to the eighth cranial nerve. So some patients administered aminoglycosides develop hearing loss and sometimes balance problems. The mechanism of this is not clear. And then nephrotoxicity is a much feared side effect of aminoglycosides. These drugs can cause acute tubular necrosis. 5 to 10% of the drug is taken up by cells in the proximal tubule, and if patients develop nephrotoxicity, you will see their serum creatinine level begin to rise. A rare but serious side effect of aminoglycosides is neuromuscular blockade. This happens because these drugs can, in rare cases, block or limit the release of acetylcholine at neuromuscular junctions, so patients will develop muscular weakness. This usually only happens when the levels get too high or when patients already have pre-existing neuromuscular disease. And then finally, these drugs are pregnancy class D, meaning you cannot use them in pregnancy. There are reports of renal and ototoxicity in the fetus. Sometimes in the hospital we will measure the plasma levels of these drugs to make sure they're at effective levels and to also reduce the risk of toxicity. We can measure a trough level, which is the level just before we give a dose. We can also measure the peak level, which is the level shortly after we give a dose. A high trough means there's more risk of toxicity, and a low peak level means there's less effective therapy. The next class of protein synthesis inhibiting antibiotics are the macrolides, and these are drugs like azithromycin and clarithromycin and erythromycin. And all of these drugs bind to the 50S ribosomal subunit, and they block the process of translocation, which is the process whereby the ribosome moves down the messenger RNA and reads the template and synthesizes a protein. So let's talk in a little more detail about how that happens. So this process depends on tRNA bringing in amino acids for the growing protein, and initially tRNA will bind to a site called the A site. Then the ribosomal RNA will catalyze the formation of peptide bonds, and there's an enzyme called peptidyltransferase that does this. The ribosome will then advance along the messenger RNA, and the tRNA will move from the A site to the P site. What macrolides do is bind to the P site, so this blocks the tRNA movement to the P site, and this is all part of the process of translocation. There's also evidence that macrolides promote tRNA dissociation from this entire process, and they may also block the enzyme peptidyltransferase. Now, normally we think about chloramphenicol as the antibiotic that blocks and inhibits peptidyltransferase, but there's evidence that macrolides may do this as well. But the easy way to just remember this is that macrolides bind to the 50S subunit and block the process of translocation. Macrolides cover many gram-positive cocci, especially strep, and this is why they're sometimes used for pneumonia. They also have some limited gram-negative coverage, and very importantly, they're concentrated inside of macrophages and other cells. This makes them effective against intracellular pathogens like chlamydia, which is an obligate intracellular pathogen, and Legionella, which is a facultative intracellular pathogen. And you may recall that both of these bacteria are causes of atypical pneumonia, and this makes macrolides good drugs to cover pneumonia because they cover strep and they also cover the atypical causes of pneumonia. So this slide lists some of the common uses of macrolide antibiotics. They're good for community-acquired pneumonia, as I was just saying, because they cover strep and H-flu and the atypical pneumonias. They're also useful in patients who have a penicillin allergy and need coverage for pneumonia. They're used for chlamydia infection. Azithromycin is safe in pregnancy, so if someone has a chlamydia infection during pregnancy, you can give a macrolide. And these are often co-administered with ceftriaxone to treat gonorrhea because chlamydia and gonorrhea often co-infect, and the macrolides do not cover gonorrhea. Erythromycin has a special property. It binds to motilin receptors in the GI tract and stimulates smooth muscle contraction. For this reason, it's sometimes given in GI motility disorders. And then clarithromycin is a drug that's part of the triple therapy used to eradicate H. pylori in people who have gastric or intestinal ulcers. The way bacteria become resistant to macrolides is they alter something called the 23S rRNA. This is a component of the 50S ribosome, and this is the location where macrolides bind. So bacteria will find a way to methylate this site, and then the macrolide won't bind and the bacteria will become resistant. Some of the side effects of these drugs include nausea, diarrhea, and abdominal pain. This is all due to increasing GI motility because, like I said before, erythromycin can bind to those motilin receptors, and erythromycin is the worst offender in terms of GI side effects. These drugs can also prolong the QT segment on the EKG. They have some potassium blocking capability, and potassium blocking drugs prolong the QT. Erythromycin is also the worst offender in this category. And then finally, these drugs can potentially, in rare cases, cause acute hepatitis. It's described as acute cholestatic hepatitis because the ALK phos tends to be elevated out of proportion to the AST and ALT, and then the bilirubin can also get elevated. There are case reports on this occurring with azithromycin, and for this reason, these drugs are contraindicated in people who have a history of cholestatic jaundice or other hepatic dysfunction. Some patients who take macrolides can get a rash. It's just a maculopapular allergic reaction. And then finally, you need to remember that these drugs are potent P450 enzyme inhibitors, so they will raise the serum levels of P450 metabolized drugs. And the two you always want to remember are theophylline and warfarin. Levels of both of these drugs can go up in patients who take macrolide antibiotics. The next group of drugs are the tetracyclines, and this family includes obviously tetracycline, but also doxycycline and demeclocycline and minocycline. And all of these drugs are transported into bacterial cells where they bind to the 30S ribosome and prevent attachment of tRNA, thus blocking protein synthesis. And one of these drugs, demeclocycline, has a very special use that you should be aware of. It's generally not used as an antibiotic, but it has a chemical structure that makes it an ADH antagonist. So it is sometimes administered in SIADH. It essentially blocks the function of ADH on the kidneys, and therefore it causes a nephrogenic diabetes insipidus to reverse the SIADH. And I talk about this more in the renal modules on sodium disorders. Doxycycline is one of the most commonly used members of the tetracycline family, and one of its favorable abilities is that it accumulates intracellularly, which allows it to be used against intracellular pathogens. It covers many unusual and atypical bacteria, so in the module on zoonotic infections that come from animals, I talk about using doxycycline to treat most zoonoses. It can also be used to treat chlamydia, which is intracellular. An additional utility for doxycycline is that it treats acne vulgaris, the facial infection. You can also use minocycline for this. It covers Propionibacterium acnes, and this gets into follicles and causes acne on your face. One unique thing about these antibiotics is that their absorption can be impaired from the stomach by minerals and antacids. So if you take calcium or magnesium as antacids, or if you take iron or drink lots of milk, it will impair absorption of tetracycline antibiotics. And the reason is because these substances are cations and they chelate the drug and prevent it from being absorbed. So you're not supposed to take these antibiotics with antacids or milk for this reason. The way bacteria become resistant to tetracycline is unique. Bacteria develop methods to decrease the influx or increase the efflux of the antibiotics from cells, and they do this through plasma-encoded transport pumps. So this is different from many other antibiotics. It's not that they alter the drug at all, it's just that they keep it from getting to its site of action by either not allowing it into the cell or pumping it out of the cell. One thing that limits the use of tetracyclines is that they have a lot of side effects. So first of all, many people on these drugs get GI distress, so they complain of belly pain and nausea and vomiting or decreased appetite. Another problem is that people get photosensitivity, so they get red rashes or blisters in sun-exposed areas. Basically, anyone who gets photosensitivity in reaction to a drug will tell you that they sunburn very easily, so they go out into the sun for a brief period of time and their skin gets bright red, and that's because of the drug. You should always remember that you can't give tetracyclines to kids, and there's two reasons for this. First of all, they discolor the teeth of children. The teeth will turn brown yellow. This only happens in children under the age of 8. It doesn't happen to adults. And then the other problem is that these things chelate with calcium when they deposit in bones, and this inhibits bone growth of children. And then finally, tetracyclines are contraindicated in pregnancy because they cross the placenta and they accumulate in the fetus bones and teeth. The next antibiotic is chloramphenicol, so this inhibits an enzyme called peptidyltransferase. So chloramphenicol binds to the 50S ribosomal subunit, and recall that macrolides do that as well, but chlorampphenicol's effect is a little bit different. So just to review what I said a few slides ago, in the process of translocation, tRNA brings in an amino acid. It binds to the A site on the mRNA. Ribosomal RNA then catalyzes the formation of peptide bonds, and the enzyme that does this is peptidyltransferase, and this is what is blocked by chloramphenicol. Next, the ribosome advances along the mRNA, and the tRNA moves to the P site, and the P site is what is blocked by macrolides. So chloramphenicol inhibits peptidyltransferase. Its effect is very similar to macrolides, but the mechanism is a little different because it's targeting this enzyme that makes bonds between the amino acids in the growing protein chain. Chloramphenicol is rarely used in the United States and other developed countries, and that's because it has a lot of toxicity and there's a lot of resistance. However, it is often used in third world and developing countries because it's relatively inexpensive. Chloramphenicol has relatively broad coverage, lots of gram-positives and gram-negatives and even atypicals. You can use it in pregnancy instead of doxycycline. So remember, I said you can't use tetracyclines in pregnancy, but if you need to treat an infection like rickettsia, which causes Rocky Mountain spotted fever, or Ehrlichia, and these are infections that are often treated with doxycycline, if you need to treat them in a pregnant person, you can use chloramphenicol. However, you can only use them in the first or second trimester because in the third trimester, there's a risk of the gray baby syndrome, which we'll talk about in a minute. You can also use chloramphenicol to treat meningitis. This is done in the developing world because it covers Neisseria meningitidis, although it's less effective than the drugs that we usually use in the United States. The main side effects of chloramphenicol are anemia and the gray baby syndrome. So you can get anemia from chloramphenicol from bone marrow suppression, but the feared complication is to develop aplastic anemia where you lose all 3 cell lines. This is an idiosyncratic reaction to the drug. It's irreversible and it's often fatal, and this is the main reason why people don't like to use this antibiotic anymore, in addition to the resistance of many bacteria. Another side effect of chloramphenicol happens when you give it to babies. Recall that babies lack the liver enzyme UDP glucuronal transferase. This is one of the reasons many babies are a little bit jaundiced at birth. Well, it turns out this enzyme is required for the metabolism and excretion of this antibiotic. So if you administer this antibiotic to a baby, their skin will turn ashen and gray, they will get hypotensive, and it's often fatal. So you can't give chloramphenicol to babies. The next antibiotic is clindamycin, and the easiest way to understand the mechanism of clindamycin is to think of it as the same as macrolides. So just like macrolides, clindamycin binds the 50S ribosomal subunit, and also similar to macrolides, it binds the 23S rRNA component, and this prevents translocation. It also has a similar mechanism of resistance to macrolides. Methylation of that 23S rRNA site will prevent binding of clindamycin, and that's how bacteria become resistant. Clindamycin covers some gram-positive, it covers some staph and some viridans strep, it covers strep pyogenes and some strep pneumonia, but its main use is to cover anaerobes. It covers Clostridium perfringens, and importantly, it covers the mouth anaerobes like Fusobacterium and Prevotella and Peptostreptococcus. The main use of clindamycin is to cover anaerobes above the diaphragm. So these types of anaerobes are involved in aspiration pneumonia, in lung abscesses, and in oral infections that include the mouth anaerobes. Importantly, there's lots of resistance to clindamycin by the anaerobe B. fragilis, which is found in the gut. So therefore, anaerobic infections below the diaphragm are treated with metronidazole, which is very effective against B. fragilis. The most important side effect of clindamycin to know about is diarrhea. So it is a classic agent to cause C. difficile infection. Up to 10% of patients who take clindamycin get a C. diff infection. C. diff causes pseudomembranous colitis. It's from C. difficile overgrowth in the colon when you change the bacteria in the gut by administering this antibiotic, and it results in massive watery diarrhea in someone who's been placed on clindamycin. It can also cause a milder diarrhea called antibiotic-associated diarrhea. This is milder than C. diff. It results from changes in the GI flora so that there's less absorption of solutes and there's a little bit of osmotic diarrhea, and this will go away when the drug's discontinued. Linezolid is a protein synthesis inhibitor that binds to the 50S ribosome and blocks the initiation of protein synthesis. And its main use is in treating vancomycin-resistant enterococcus, or VRE. This bacteria is very dangerous and has caused epidemics in hospitals. It usually occurs in a patient who's been treated with antibiotics previously and now is sick with a resistant bacteria. A special side effect of linezolid to know about is that it's a weak monoamine oxidase, or MAO, inhibitor. This means that it can potentially cause the serotonin syndrome, especially if you give it together with selective serotonin reuptake inhibitors, or SSRIs. And I talk about the serotonin syndrome in the neurology modules, but the symptoms are fever and confusion and agitation and hyperreflexia. And if you see that happening after someone's been administered linezolid, it's because of MAO inhibition. There are two streptogamin drugs. These are quinupristin and dalfapristin. Both of these drugs bind the 50S ribosome, and they're used together in a medication called Sinersid to sequentially block protein synthesis. And the use of this drug is for vancomycin-resistant bacteria, like vancomycin-resistant Staph aureus and vancomycin-resistant Enterococcus. These are rare but deadly bacteria, and these are sometimes called the antibiotics of last resort for these type of highly resistant bugs. Let me finish this module by discussing which antibiotics are bacteriostatic and which are bactericidal. Almost all of the protein synthesis inhibitors are bacteriostatic. That's because they stop protein synthesis, but they don't kill the cell. The one exception are the aminoglycosides. These cause misread proteins to travel to the membrane of the cell and increase permeability, and then the bacteria die. Linezolid is mostly bacteriostatic, although it's bactericidal for some bacteria. You don't need to know that. And Sinersid has variable cidal versus static activity. But for the majority of the protein synthesis inhibitors, you can just remember that they're bacteriostatic because they block production of proteins. The one exception is the aminoglycosides. And that concludes our module on protein synthesis inhibitors.